All right, welcome to the first of 2 weeks of cardiology. We're now in Unit 3. We're halfway through this course, so light at the end of the tunnel. Let's keep going here. The 3 big pathologies we'll be looking at will be hypertension, coronary artery disease, and congestive heart failure. But let's start up with a really quick review of cardiac anatomy and cardiac physiology. We're going to blow through this quickly. If you need to go back and review that, then chapter 31 in the text, particularly those pages right there, 1124 to 26, are a pretty good summary of what we're going to cover here really briefly. So the heart lies centrally in the chest, underneath the sternum, with the apex projecting towards the left, underneath the 2nd through the 5th rib. Remember, the heart is covered in pericardium, so that pericardial sac provides a frictionless surface, very similar to what the pleura does for the lungs. The space between the pericardium and the outer heart, the epicardium, is a potential space. There should be no fluid in the pericardial sac. The myocardium refers to the heart muscle, and the endocardium is the inner lining of the ventricles, atria, the valves, and all the great vessels. Major great vessels are the inferior and superior vena cava coming into the right atrium, bringing deoxygenated blood back to the heart. The pulmonary veins, bringing oxygenated blood from the lungs back to the left atrium. Pulmonary artery, leaving the right ventricle, carrying deoxygenated blood to the lungs. Aorta, leaving the left ventricle, carrying oxygenated blood to the body. And then the heart, again, divided in upper and lower chambers. 2 upper atrium, right and left. 2 lower ventricles, right and left. And the the right and left ventricles are also each separated so that oxygenated and deoxygenated blood is not mixing. Here in a cadaver section, you can see the central location of the heart with the right and the left ventricles, with that left ventricle apex slanted downward and towards the left. You can see the pericardial covering over the heart in the same way that you can see a lot of the pleura covering over the 2 lungs. And then looking at the primarily right side of the heart here, you can see the superior and inferior vena cava coming back to the right atrium. You can see the pulmonary artery coming out of the right ventricle, again taking blood to the lungs. The pulmonary artery is in front of the aorta. Now you got a picture of the aorta behind it coming down with it projecting out of the left ventricle, bringing oxygenated blood to the body. And then you can also see in this dissection, you can also see a number of the coronary arteries, which we'll be covering later in this unit. So the heart is a pump. The heart is primarily composed up of muscle. All muscle needs electrical activation in order to contract. So in the heart, we both have contractile cells, which make up the pump, and conducting cells, which are actually neurons, sending the electrical information to those conducting muscle cells. Both types of cells are highly dependent on oxygen, and without a continual supply of oxygen, both contractility and conduction has become adversely affected. And we'll talk about the effect of coronary atherosclerosis in reducing O2 delivery to these types of cells. Oxygenation of the heart is provided by arteries. The left and the right coronary artery are the first takeoffs of the aorta. And you can see that the right and left coronary artery divide into a number of different branches, which are then going to go and supply oxygenated blood to the right and the left side of the heart. In terms of the anatomy here, the arteries that I'm going to want you to know and understand where they're going are the right coronary artery and the right coronary artery, and then the left coronary artery dividing into the circumflex artery and the anterior interventricular artery, sometimes also referred to as the left anterior descending artery. So remember, the heart does not extract blood from the atrium or the ventricles. It requires its own blood supply, and that blood supply comes off the base of the aorta as the right and the left coronary artery. Moving blood through the heart, so if we follow it from the right side, the two vena cava will bring deoxygenated blood to the right atrium, through the right atrium into the right ventricle, out the right ventricle into the pulmonary trunk or the pulmonary artery, which then splits to right and left, carrying that deoxygenated blood to the two lungs. In the lungs, blood's going to pick up oxygen, and that oxygenated blood will be returned to the left atrium via typically 4 pulmonary veins, out the left atrium into the left ventricle, and then blood ejected out the left ventricle into the aorta and out all the branches of the aorta to the rest of the body. In terms of the heart valves separating the atrium from the ventricles, we have both a right and a left atrioventricular valve. On the right side, it's referred to as the tricuspid. On the left side, referred to as the bicuspid. And these are the two valves which will have the strings or the chordae tendae. And the chordae tendae are going to prevent the prolapse of those valves back up into the atrium when the ventricles contract. So when we're going to move blood from the atrium into the ventricles, those valves need to be opened. And then when we eject blood out of the ventricles, those valves need to shut. The chordae tendae are the anatomical structures which allow that to happen. And then we have valves from each ventricle, separating the ventricle from the great vessel. So a pulmonary valve on the right side and an aortic valve on the left. Those valves need to be open when the ventricles contract, and then they need to close when the ventricles relax and fill, that way preventing regurgitation of blood backwards from the great artery back into the ventricles. We talk about systole and diastole in a minute or two here. I'm going to want you to be able to identify which of those valves are open and closed in each of those two parts of the cardiac cycle. So in diastole, that refers to the ventricles filling. Blood is moving from the atria into the ventricles, and at the very end of diastole, the atria will give a little contraction and force more blood down into the ventricle. In diastole, the AV valves are open, and the pulmonary and the aortic valves are closed. In systole, now the ventricles are going to contract and eject blood out of the great vessels, so the AV valves should be closed. At the beginning of systole, as the ventricles start to contract, the pulmonary and the aortic valves are closed until enough pressure is generated to open up those valves, and then the ventricle fully contracts and ejects blood up into the pulmonary artery and into the aorta. So in systole, AV valves are closed, and the pulmonary and the aortic valves are open. So the cardiac cycle is a series of filling the ventricles and contracting the ventricles, diastole, systole, diastole, systole. And if you were to feel your radial pulse right now, each time you feel a pulse, that is systole. Those are the ventricles contracting and ejecting blood. And each time your pulse goes away, that's the relaxation phase. When the ventricles are filling with blood, that is diastole. So just think of the cardiac cycle as fill, eject, on and on. Like I said, the heart is primarily made of muscle. That muscle has a conducting neurons, and we're going to talk more about the conduction system and normal sinus rhythm and cardiac arrhythmias in Unit 2. This unit, we're primarily going to focus on the pump or the muscle. So you can see the gross anatomy of the heart showing you all that nice, thick, juicy myocardium or muscle in the ventricles. A light microscopy then shows you the histology of cardiac muscle. Cardiac muscle, like skeletal muscle, is made up of actin, myosin, troponin, and tropomyosin. If you recall from your days of undergraduate physiology, in order to get the ventricular muscle to contract, you need to break apart cellular energy in the form of ATP, and you need calcium. Calcium binds to troponin. Troponin pulls tropomyosin off of actin, and then actin and myosin bind together. The myosin will contract, and the contraction of that myosin will lead to the contraction of filaments, and thus the contraction of the muscle, and the ability of the muscle to contract and eject blood either out of the atrium into the ventricles or out of the ventricles and into the great vessels. So maybe the most important parts of this slide here is to understand where troponin is, because we're going to use troponin levels in diagnosing MI, myocardial infarction, and understand the role of calcium and ATP in order to get healthy contractions of the heart. Again, two types of cells continually in action in the heart are the contractile cells and the conduction cells, and both need a steady supply of oxygen, glucose, electrolytes, and they must be continuously generating ATP in order to make all that metabolic activity, particularly the conduction and the contraction, to occur. So the heart cells are very aerobic, using that glucose and oxygen to generate ATP. That ATP is necessary for cardiac conduction, contraction, and maintaining the integrity of the cell membrane. Cardiac output then describes the amount of blood that the heart pumps around the body in 1 minute. And at rest in a healthy adult, that's typically about 5 to 5.5 liters. So 5 to 5.5 liters of blood is pumped through the heart every minute. That's referred to as cardiac output. Remember, cardiac output is never fixed, and it must be able to change from resting to dynamic. So you need some cardiac output when you're at rest, but if you start running, going up and down stairs, doing any other type of physical activity where more blood and more oxygen is going to be needed into the body, cardiac output is going to have to increase. You're going to have to increase the amount of blood being pumped through the heart. So in terms of the numbers, a healthy human heart will beat about 60 to 100 times per minute. The left ventricle fills with about 150 to 175 milliliters of blood. It will eject between 55 to 120. So as you see, the ventricle never fully ejects all of the blood out. There will be some residual blood. Cardiac output can vary between 4 to 8 liters per minute. And in an individual with really good athletic conditioning, that cardiac output can actually increase beyond 8 liters. And the ejection fraction describes the amount of blood ejected out of the ventricle compared to the amount of blood that it filled with. So the stroke volume over the end diastolic volume gives you the ejection fraction. At rest, that's about 50 to 55%. But with good athletic conditioning, that ejection fraction can increase to even better than 75%. So again, during exercise, these parameters are going to change. Increase your heart rate, increase the filling of the ventricle, and increase the amount of blood ejected out of the ventricle, increasing the stroke volume and thus increasing the amount of cardiac output. So now again, physical activity is going to require increased amount of blood flowing through the heart and blood flowing around the body. So cardiac output is going to have to be increased. So physical activity, shoveling, walking upstairs, walking in general, lawn work, arguing, eating a big meal, activities which may be going on in the bedroom, right? All this type of stuff is going to increase cardiac output. And as we move on into this, as we move on through this unit, we're going to talk about what happens when an individual starts to get involved in these activities, but cardiac output can't be increased, or oxygenation of the heart can't be increased due to underlying pathologies. Okay, what controls cardiac output? There are 2 factors that control cardiac output: heart rate and stroke volume. An important equation to remember is cardiac output equals heart rate times stroke volume. We're going to talk more about heart rate in Unit 2 and what are the factors that increase or decrease heart rate. Remember, that's primarily the autonomic nervous system, where the sympathetic side, fight or flight, will increase heart rate, and the parasympathetic side, rest and digest, will bring heart rate down. We can actually change our stroke volume. We can't consciously do that. That's part of the autonomic nervous system, primarily the sympathetic side. But the way that we increase stroke volume is by giving the heart greater contractility. That occurs through the beta 1 receptor. We'll look at that in a minute. And we can also increase stroke volume by bringing more blood into the heart. So if we increase the filling of the ventricles with more blood, that will in turn result in a higher stroke volume. A higher stroke volume is going to give us more cardiac output. You may have seen this in an undergraduate class. This is the Frank-Starling curve. This describes a normal, healthy heart. And what it's saying is the more blood you put in the ventricle, the higher is the end diastolic pressure at the bottom on the x-axis, the greater will be the stroke volume, how much blood is ejected out the ventricle, shown on the y-axis. Now eventually there's going to be a plateau. You can't put 10 liters of fluid into a heart and expect that it's going to be able to still function properly. So eventually there's going to be a plateau. But for a normal, healthy heart, the more volume that goes in, the greater stroke volume can occur. How do we get more volume moving into the heart? Through skeletal muscle contraction. By contracting muscles, we contract veins, and contracting those veins pushes more blood into the vena cava, back into the right atrium, and then starting to fill the heart. Here is the Frank-Starling curve under sympathetic tone. So in the fight or flight response, under the autonomic nervous system sympathetic side, beta 1 receptors are stimulated, and those beta 1 receptors will actually give the heart greater contractility for the same amount of filling pressure. So as you can see what's happening at rest in the green curve, and then under the sympathetic stimulation for the same amount of diastolic filling, we're getting an increased stroke volume. So remember, cardiac output equals heart rate times stroke volume. Increase the stroke volume, you get better cardiac output. And we'll talk about that beta-1 receptor in a minute or two here. Here's the conduction system of the heart. So again, remember, muscle does not contract without receiving electrical impulses. So the SA node to the AV node, down the bundle of His, and then down the Purkinje fibers in the right and the left ventricle, that supplies the electrical activity to generate both contraction of the muscle and relaxation of the muscle. And we're going to cover this in more detail, normal sinus rhythm and arrhythmias in Unit 2. So we'll just put this one on the back burner for now. Here's normal sinus rhythm. And again, a lot of you see normal sinus rhythm all the time in your patients on cardiac monitors, and we'll talk more about this in detail in the next unit. The SA node begins the electrical excitation. That electrical movement moves through the atrium into the AV node. From the AV node, then it moves down into the ventricles through the septum, through the bundle of His, and then it spreads into both the right and the left side through the right and the left bundles. And then that electrical excitation in the ventricles causes the ventricles to contract from the apex upward. And by doing that, by contracting in that manner, it's going to move the blood up and out of the pulmonary artery on the right and out of the aorta on the left. Remember, the SA node is the pacemaker, and it is the SA node that initiates that electrical conduction. All right, vessels really quickly. Vessels have 3 layers. All vessels have an inner endothelial layer. We talked a little bit about the endothelium when we talked about platelets and coagulation. Remember that? The endothelium is that slippery, non-sticky surface to which things should not be attaching. If the endothelium is damaged and von Willebrand factor gets exposed, then we start seeing platelet aggregation. So capillaries, arteries, and veins should all have intact endothelium, allowing the blood to move through easily without coagulation. Arteries and veins are then going to have a muscular layer, usually referred to as the tunica media, and then they will have an outer connective tissue layer, the tunica adventitia, kind of holding it all together. If you look at the difference between arteries and veins, arteries are far more muscular, going to have much more smooth muscle in that tunica media than will be the veins. Artery is going to be a little bit more difficult to collapse. Veins are going to be a little bit easier to collapse due to the lack or less amount of muscle in there. In the muscular layer are 2 receptors. The alpha-1 receptor, which when fired, will cause the muscle to contract, decreasing the size of the lumen of the vessel, so vasoconstriction. And the beta-2 receptor will cause that muscle to relax, opening up the vessel, vasodilating. Vasodilation then is going to result in increased blood flow through that vessel. So alpha-1 and beta-2 are found on the muscles in both artery and veins. Alpha-1 vasoconstricts, beta-2 vasodilates, and we do not have any smooth muscle on the capillaries. The capillaries are primarily just composed of the endothelial layer. And here we can see a nice histology of an artery and a vein where you can see all 3 of those layers. And again, notice the increased tunica media, or the increased smooth muscle around that artery. Guys, ever been in downtown Manhattan? You know that downtown Manhattan is an island, and to get things in and out of that island, You got a bunch of bridges and tunnels, and you know that at certain times of the day, those bridges and tunnels get blocked with traffic, right? And it becomes almost impossible to get in and out of the city because of all the blockage and congestion on those bridges and tunnels. So when we think about coronary artery disease, I think of the heart as a little city where those conduction cells and contractile cells want goods and services, particularly oxygen and glucose. And the way to get that oxygen and glucose into the city is via the coronary arteries. And those coronary arteries can get blocked in the same way that the bridges and tunnels of Manhattan can get blocked. The bridges and tunnels in Manhattan get blocked by cars and taxis and trucks and crazy people trying to walk, right? The highways of the heart, the arteries of the heart get blocked with plaque, with atherosclerosis. So atherosclerosis, plugging in those arteries, is going to inhibit the delivery of oxygen and glucose and necessary nutrients to those cells of the heart. So we're going to spend some time talking about atherosclerosis and the effect of atherosclerosis on impaired conduction and impaired contractility. So atherosclerosis, also known as coronary artery disease or plaquing or atheroma, is the accumulation of junk in those vessels, and the more of this plaque which accumulates, the smaller and smaller the lumen of the vessel becomes. Then the smaller the lumen of the vessel becomes, the less capable that vessel is going to be in delivering oxygen and critical nutrients to its destination cells. So the histologic picture at the upper left shows a nice open artery. Remember, the endothelial layer is the inside layer. The muscular layer is that heavy pink layer. And then the outer connective tissue layer is that less dense adventitia. Move over to the right histologic picture, and now you see a vessel that kind of looks shrunken down. That lumen, that white open area, has got a lot less space to it, and that arrow is pointing right into the plaque. The plaque builds up in the vessel wall. What do I mean? The plaque builds up underneath the endothelium. The plaque doesn't really build up in the lumen, but by the plaque building up in the endothelium, under the endothelium and expanding, it crowds and crowds the lumen more and more, narrowing down the lumen size, or the lumen radius. So that plaque is actually accumulating underneath the endothelium, but within that tunica media. And the more plaque you get in there, the less muscle you have in there. That means the vessel becomes less elastic, less able to relax and open up and vasodilate, meaning less able to increase the O2 supply through that vessel. If you look at that plaque, you see that that plaque is stained a lot of different types of colors. That tells you that that is a very heterogeneous composition of that plaque. People like to think that the plaque is primarily precipitation of crystallized cholesterol, and there certainly is precipitated cholesterol in that plaque, but that plaque is more than cholesterol. There's a lot of stuff in there. Other lipids, inflammatory cells, hemorrhagic cells, fibrotic scarring cells, and calcium. And the deposition of calcium in that plaque makes the artery stiff and rigid. You can also say that's non-compliant or non-elastic, making it difficult to vasodilate, open up, and increase blood flow through that vessel. So coronary atherosclerosis is also known as hardening of the arteries. If you were ever in a cadaver lab and your cadaver had significant atherosclerosis of any great vessel, you can actually feel that, and it kind of crunches when you put your fingers on it and squeeze it, and that's due to the calcification in that plaque. And then if you look at that lower left picture, it's kind of showing you a vessel, showing you plaque in the vessel. That photo is a little bit wrong because they're showing you the plaque kind of in the lumen of the vessel. Remember, that plaque is not in the lumen, it's accumulating underneath the endothelium in that muscular layer. So take a look at the middle picture there, and you can see how that plaque is primarily, you see it kind of in the lower right side. See how that plaque, as it's accumulating in the vessel wall, is impinging into the lumen and narrowing that lumen. So if you looked at that vessel, you can then judge what percent occlusion you have. And I might say that that vessel there probably has what? 40 to 50% occlusion, maybe low, maybe more. See what I mean by saying percent occlusion? Thinking how open that would be if all that plaque wasn't there, and then try to estimate what percent of that is due to the plaque. Okay, you know this. That plaque is referred to as atherosclerosis. So what are the risk factors for coronary atherosclerosis, or the risk factors for building up plaque in the coronary arteries? Take about a minute here before you move on to the next slide and list some factors. I'll give you one: smoking. You know that smoking is definitely a significant risk factor for coronary atherosclerosis. And here is a really nice summary slide showing you all the different things that contribute to atherosclerosis. Remember, that plaque has lipid, that plaque has inflammation, that plaque can be calcified. So since that plaque is very heterogeneous, you would expect there to be numbers of different risk factors for coronary artery atherosclerosis, and we will be covering a lot of these risk factors in more detail as we move on. We'll spend a fair amount of time talking about hypertension, maybe the most important risk factor for coronary atherosclerosis. We'll talk about hypertension here in the next dozen slides or so, and then next week we'll talk a little bit more detail regarding the lipids, particularly things like HDLs and LDLs and very low density lipids. We'll get into that a little bit in this unit, but a lot more so next unit. Diabetes, sedentary lifestyle, increased body fat, right? A lot of different risk factors for coronary atherosclerosis, and they're all listed here on this slide. Okay, hypertension. We said that hypertension is a major risk factor for atherosclerosis. Hypertension is a major risk factor for a number of different end organ pathologies: the heart, the brain, the kidney, peripheral blood vessels, and the retina can all be adversely affected by hypertension. We're going to talk a lot about the effect on the heart as we move through this unit. We'll get to the brain, the kidneys in subsequent units, and we will talk about peripheral arterial disease a little bit more in Unit 2 of cardiology. Good point to remember about this slide is hypertension is going to have adverse effects on all types of blood vessels, and its primary, the three big organs at risk for damage due to hypertension are going to be the heart, the brain, and the kidneys. Hypertension is really a function of advancing age. The older we get, the greater is the amount of that aged population who has underlying hypertension. But again, remember, even young adults in the 20s and 40s, we still have somewhere between 10 to 15% of that younger adult population with hypertension. But as you can see, as you move into the 40s, 50s, and 60s, In 60s and 70s, you can see that the percent of individuals, both male and female, the percent of individuals with hypertension go up. So one risk factor for hypertension definitely is advancing age. Another way of looking at how prevalent hypertension is to look at what are the top 10 prescribed generic drugs in the US. And you can see that 3 of the top 10 are antihypertensives. Lisinopril, an ACE inhibitor, amlodipine, a calcium channel antagonist, and hydrochlorothiazide, a diuretic. They all fall in the top 3 of the most commonly prescribed generic drugs in the US. And in this unit, we'll talk a little bit about antihypertensive drugs. I can't help myself. I love talking about drugs. So even though this is not a pharmacology class, you know me now, that you know that I'm going to talk a lot about drugs in each of these units. So we'll get into some of the actions of these antihypertensive drugs as we move on here. Okay, I am the last person to tell a group of experienced clinical nurses how to do an appropriate blood pressure, but humor me for a second and let's just go through this and be sure that we do this right, okay? All right, sitting and relaxed, feet on the floor, arm at heart level. Appropriate cuff size should be covering 80% of the upper arm. Do 2 readings and always confirm your blood pressure in each arm. Individuals should not be under the influence of meds which can increase blood pressure, like caffeine or cocaine and methamphetamine, right? The time to do a blood pressure on someone is not after they've done a line of coke. Consider the white coat syndrome. Some people are going to be anxious at healthcare visits, right? So their blood pressure due to anxiety, fright, fear, whatever, is going to be up a little bit. And I already said that. Be sure feet are on the floor with the arms supported at heart level. Okay, you guys already knew that, but again, just a quick review. Blood pressure. Blood pressure is the force that blood exerts against the inner walls of the vessel. So remember, you got a vessel, which is a hollow lumen. You've got volume inside that hollow lumen. So that volume is going to have some type of pressure on the vessel wall. As the heart contracts and pushes blood out, you're also going to get pressure pushed against the vessel wall due to systole, right? That's why you're feeling your pulse in systole. As the heart contracts, you're feeling that pressure wave of blood moving forward, right? So therefore, we have an upper and lower number in blood pressure. We have a systolic number and a diastolic number. And normal blood pressure is considered to be 120/80 in a standard size healthy adult. And we know that in pediatrics, blood pressure is going to change. So in pediatrics, you got to know what age you're dealing with, because what might be hypotension in an adult might be absolutely normal blood pressure for a school-aged child, or particularly for an infant. So no need to be memorizing any numbers with respect to pediatrics, but I am going to have you memorize numbers with respect to what is normal blood pressure and what is considered to be hypertension for an adult. So here's an automatic cuff, and this person's blood pressure is 140/88. So what do you think? Is that person hypertensive? And what stage of hypertension would you give that individual? So let's answer those 2 questions in the next couple of slides here. Okay, the American College of Cardiology and the American Heart Association has released a hypertension guideline in 2017. I took a synopsis of that guideline as a PDF file and I posted that up on Blackboard. So this is where a lot of my reference information now regarding hypertension is coming from that recent guideline from the American Heart Association. In healthy adults, normal blood pressure less than 120/80. Elevated blood pressure, 120s, but less than 80 diastolic. Stage 1 hypertension, 130s over 80s, and stage 2 hypertension greater than 140, greater than 90. There should be a greater sign over that 90 there, okay? So you always take the higher number of the two, and then you stage your individual. So that individual that we just saw, whose blood pressure, 140 over 88, you would stage that person as a stage 2, right? That's kind of like right on the cusp. You'd probably be watching that for a little while before you committed one way or another, but let's make it easier. Let's say that person was consistently running a blood pressure of 145 over 150 with diastolics of 92 to 96, right? We would consider that, based on this guideline, we would consider that to be stage 2 hypertension. Should you commit those numbers to memory? Yes, you should commit those numbers to memory. Those are important numbers. Okay, once we have identified an individual as being consistently hypertensive, one of the things we want to think about is, why are they hypertensive? So some individuals have what's called a secondary cause. A secondary cause means that they've got some underlying pathology that's leading them to have hypertension, and that pathology can be reversible. If we can get on top of the pathology and reverse the pathology, we would expect their blood pressure to come back to normal. About 1 in 4 adults have an identifiable secondary cause. Most adults with hypertension have what's referred to as essential hypertension. We'll talk about that in the next slide. Here's some causes of secondary hypertension: sleep apnea, use of drugs, particularly stimulants and steroids, kidney disease, aldosterone secreting tumor, renal vascular disease such as renal artery stenosis, individuals who are taking excessive glucocorticoid steroids because of the drug neuron such as prednisone, or maybe they have an ACTH or cortisol secreting tumor leading to Cushing's syndrome. We talked about that in the endocrine unit. Pheochromocytoma, tumors of the adrenal medulla, releasing catecholamines like epinephrine and norepinephrine. We talked about that. Vascular diseases such as coarctation of the aorta. That's why it's important to look at both right brachial and left brachial blood pressures. If we're really high on one side, lower normal on the other, we got to think of some type of coarctation potentially in the thoracic aorta. And thyroid diseases, right? Hyperthyroidism can lead to hypertension. So it's important to understand secondary causes of hypertension. An individual who has persistent hypertension need to think about that, and they may need to be worked up for some of these vascular, endocrine, or renal pathologies. And again, always ask about drug intake. You're looking at an individual who's persistently hypertensive, consider what they're taking over the counter: decongestants, stimulants, think of prescription things like stimulants, Adderall, drugs of abuse like cocaine and amphetamines, and obviously the steroids like prednisone and all those other systemic glucocorticoids that we talked about. All right, about 1 in 4 adults with hypertension will have a secondary cause. Most adults with hypertension are going to have what's referred to as essential hypertension. Terms that you'll see, they're older terms. Most literature won't use primary or idiopathic hypertension anymore. Most of the time you're going to see it referred to as essential hypertension. These individuals usually have some risk factor which is causing them, some risk factor which is increasing their risk of hypertension, and that's referred to as a hypertensinogenic risk factor. So if you're overweight, if you're smoking, if you have a high sodium diet, lack aerobic lifestyle, high alcohol intake under a lot of stress. Now I know a lot of you are looking at that and saying, well, isn't that a secondary cause? If you're overweight and you're smoking, then you lose weight and you stop smoking and you stop binge drinking, your blood pressure comes down. You're right. You're absolutely right about that. So that's where I'm confused too in some of the terminology between secondary and essential, because to me it looks like a lot of these hypertensinogenic risk factors are in fact acquired, and if you stop that acquired behavior, you can reduce your blood pressure, right? So it is a little bit confusing to me. I'll also admit that, but this is the way that it is presented in the text and in the review articles as well. You know that factors can be additive. So if you're sedentary and overweight, you're not exercising and binge drinking and smoking, right? Additive accumulation of hypertensinogenic risk factors going to make your hypertension worse. And there's certainly a genetic component to this. So we are all different in our glucocorticoid and our aldosterone and autonomics in terms of metabolic activity, in terms of receptor function. So the more and more we learn about the genetics and the more we learn about the basal action of these hormones in different people, and particularly in different populations, such as Black versus Caucasian, men versus women, postmenopausal woman versus young adult woman, the more we start to understand what essential hypertension is really all about. But in terms of how it's presented, we're going to look at these hypertensinogenic risk factors at increasing one's risk of elevated blood pressure. I hope that kind of makes sense. I'm not going to get really picky in the questions here, but I do want you to understand some of those important secondary causes, and I definitely want you to be able to list these risk factors. Okay, renin-angiotensin system. You've seen this in undergrad physiology. Let's go through it really quickly. The liver releases an inactive protein called angiotensinogen. The kidney releases an enzyme called renin. Renin will cleave angiotensinogen to a protein called angiotensin 1. The lungs release another enzyme called ACE, angiotensin converting enzyme, and that will convert angiotensin 1 to angiotensin 2. And angiotensin 2 then is the active protein. Angiotensin 2 causes vasoconstriction, raising blood pressure. Angiotensin 2 causes the release of aldosterone from the adrenal gland, and aldosterone then results in increased sodium and water retention in the kidneys. So we hold on to more sodium and water. And the combined effect of vasoconstriction and increased sodium water retention brings blood pressure up. That's a good pathway to have in the body when we are in a state of dehydration or anything else that results in low blood pressure, whatever that might be. We need that to stay alive. So the renin-angiotensin system preserves blood pressure, but excess activity of that system can lead to hypertension. So in an individual with essential hypertension, one of the thoughts is that somewhere in this renin-angiotensin system, it's been excessively activated or turned on. We're having too much activity, getting too much vasoconstriction via the action of angiotensin 2, and too much water and sodium retention via the action of aldosterone. All right? So this is an important system to understand, because a lot of our antihypertensive drugs come into play in this pathway, and this pathway is really important to understand when we talk about heart failure. So I would actually ask you to take out a piece of paper and draw this out a couple of times. Draw out where all this stuff is coming from and what it's doing, which of these proteins are enzymes, which of these proteins are active, which of these proteins are inactive. And again, remember, aldosterone is not a protein, it's a steroid. All right, do that one once or twice and review that so you get a good understanding of that. All right, in terms of antihypertensive therapy, why do we want to treat hypertension? Well, the biggest reason to treat it is to reduce the morbidity and mortality on the heart, the blood vessels, and the kidneys, right? So by treating hypertension, we're trying to reduce the impact of cardiovascular disease and the impact of chronic kidney disease. You have a couple different guidelines that are out there. In terms of the guideline that I'm using, that 2017 American Heart Guideline, what they're saying is we want to be treating adults, we want to be getting them to a goal of less than 140 over 80. In an elderly person, so an individual over the age of 60, maybe not so aggressive, because if we treat them aggressively, we increase their risk for syncope and passing out and falling. So maybe we lighten up a little bit based on age. But our target in general is we're trying to get them to less than 140 over 80. An individual with underlying risk factors like diabetes or underlying kidney diseases, these guidelines are actually saying we can treat them even a little bit more aggressive and try to get them to a goal of 130 over 80. Because hypertension in and of itself is going to make diabetes worse, and it's going to make kidney disease worse. So a good clinician identifies hypertension, looks for secondary causes, works up and treats secondary causes, and then initiates counseling with respect to the hypertensinogenic risk factors, those lifestyle modifications which need to be done that are going to help bring your blood pressure down, whether you have a secondary cause or it's essential. And then a good clinician understands what pharmaceutical drugs are available in the algorithms that determine how do you pick and choose. So we can do this really, really quickly here and take a look at this. So lifestyle modifications, very important. It's like diabetes, right? You got all these drugs to treat type 2 diabetes, but if you ain't controlling your diet and your weight and exercising, you know, you can take all those $1,000 a month drugs, but you're just kidding yourself if you're thinking that your A1C levels are going to be dropping. Same thing with hypertension. You can put your individual on an antihypertensive drug, but if they're not losing weight and they're consuming a lot of sodium and you got physical inactivity and drinking a lot of alcohol, right? There's only so much those drugs are going to do. So take a look at this, right? And you can see just by lifestyle interventions alone, you can get some pretty significant dents in hypertension and start driving that systolic blood pressure down to that 130 to that target of less than 140 that we're trying to get our individuals to. You guys know what the DASH eating plan is? I think I got this in the next slide here. Hold on. Yeah, here's the DASH eating plan. Dietary approaches to stop hypertension. All right, I think all of you understand that, and particularly if you're working in primary care and family practice, you understand what the DASH diet means, right? Cutting out the sodium, cutting out the fats, cutting out the processed meats and the carbohydrates, and going to more natural grains, vegetables, and fruits, right? All right, that's pretty simple. We probably should all be doing this stuff. We could probably all be better at doing this, right? All right, here's a nice algorithm that comes out of that. Here's a nice algorithm that comes out of that American Heart Association guidelines. So if we look across the top, normal blood pressure, elevated blood pressure, stage 1 and stage 2 hypertension. And even in those individuals with stage 1 and stage 2 hypertension, it's extremely important to do that non-pharmacologic therapy, those lifestyle modifications. And it's only when those lifestyle modifications have failed to get the blood pressure down, or when their cardiovascular risk is elevated, that we start then bringing in the pharmacologic therapy. And we'll look at what the pharmacologic therapy or what the options are here in a minute or two here, in a slide or two here. But it's important. The reason I put this algorithm in here is to, again, show you the staging of hypertension and show you the importance of lifestyle modification and the importance of reassessment. Make an intervention, reassess it in a couple of months and see what's going on with the individual's blood pressure. Okay, ambulatory management. What type of drugs do we have available? We have diuretics, get rid of sodium in water. We have diuretics that work in the loop. We'll talk about the renal nephron in a couple of units here, but loop diuretics like Lasix, those are the most important. Tubule diuretics like hydrochlorothiazide, that's probably the most commonly used diuretic. Usually you see the loop diuretics used more inpatient for individuals with severe hypertension or heart failure, right? You really diurese a lot of salt and water off an individual by those types of drugs, particularly when given IV. ACE inhibitors, inhibiting ACE enzyme, they all end in pril, P-R-I-L. Lisinopril and enalapril being the two most common. There are 10 ACE inhibitors on the US market. Angiotensin II receptor blockers, also referred to as ARBs. They all end in the sartan, valsartan, losartan, the most commonly used in the US. There's 7 of those on the market. And then an aldosterone antagonist spironolactone. So the diuretics, the ACE, the ARBs, and the aldosterone antagonists are all counteracting that renin-angiotensin system where you're getting excess vasoconstriction and excess sodium and water retention. If we dilate blood vessels, you know, when we dilate blood vessels, that reduces forces within the vessel, so that vasodilation is an effective way for treating hypertension. We have 2 major classes of drugs that are vasodilators, the calcium channel blockers. Those end in pine, amlodipine, nifedipine, right? Probably 2 of the more common, 7 of those on the market. Alpha-1 blockers, terazosin, doxazosin, prazosin. Those are pretty hardcore drugs. Those can lower your blood pressure fairly dramatically and put an individual at risk of hypotension and syncope and falling. So you got to be a little bit careful with the alpha ones. Those are definitely not first-line drugs. You have drugs which act in the central nervous system like clonidine, and then you have a newer drug on the market now, which is an actual antagonist to the renin enzyme, aliskiren. Again, not a first-line drug. Typically, your first-line drugs are your top 4. Diuretics, ACEs, ARBs, and aldosterone antagonists. And then for an individual with persistent hypertension, you can then start looking at add-on therapy, such as a vasodilator or a CNS acting drug or a direct renin antagonist. And I'm sure you'll cover a lot more of the detail of these drugs in a pharmacology class. A good exercise to do is write out your renin-angiotensin system, and then after you have it written out, then look at these drugs, take these drugs and fill in where these drugs act, right? So as an example, spironolactone, you should put that next to where you have your action of aldosterone. And that's just a nice way of reviewing that renin-angiotensin system and a good way of doing a quick review of mechanism of action of those antihypertensive drugs. So that was a quick review of hypertension. And remember, hypertension is the most important risk factor for atherosclerosis, or the accumulation of plaque within blood vessels, particularly arteries. So now let's talk specifically about coronary atherosclerosis and acute coronary syndrome. What are the consequences of plaquing up coronary arteries and reducing the lumen and reducing the blood flow through those arteries? Then next week we'll talk about peripheral atherosclerosis and the consequences of plaque in peripheral blood vessels. And then eventually when we get into the neuro unit, we'll talk about cerebral arteries and the consequences of cerebral atherosclerosis. All right, so looking at this plaque, you can see that this plaque is narrowing down the lumen. Remember, that plaque builds up underneath the endothelium, builds up within the vessel wall, not within the lumen itself. But the more plaque you put in there, the narrower and narrower the lumen gets, minimizing the amount of blood flow that you can get through that segment of artery. As you put more plaque into the tunica media, you reduce the amount of smooth muscle in there, so you get arteries then which are less elastic or less compliant. And that becomes problematic when it can't vasodilate and increase blood flow. Think of somebody who's got fixed stenotic lesions in the coronary arteries, and then they try to do something such as increase cardiac output, and increase your cardiac output, you got to get vasodilation of your coronary arteries. You got to get more blood moving through your heart muscle. And if you can't do that, that's going to be problematic. Atherosclerosis is also referred to as hardening of the arteries, because within that plaque, you're going to get fibrosis and you're going to get calcification. It's a fibrosis and calcification that's going to make that artery more rigid and less elastic. And then again, you can judge what's the percent occlusion by looking at how much that plaque has narrowed down the lumen. So if this blood vessel here, if this blood vessel were fully opened, what do you think? Do you think this is about 70% occlusion? Maybe a little bit less? I don't know, but I think that's a relatively good guess, right? Okay, let's move on here. I said we're going to talk a lot more about the fat part of atherosclerosis in Unit 2, but let's look at some of this right now. Fat will accumulate below the endothelium or subintimal, and that deposition of fat and proteins associated with fats on low-density lipids will result in the accumulation of cholesterol and other fatty acids, etc., in that plaque. As that plaque accumulates, macrophages are going to suck up some of that fat, and inside the macrophage, they're going to oxidize that fat. And that oxidized fat is going to generate an inflammatory response. So I said that there's inflammation in the plaque. The inflammation in the plaque is due to oxidation of lipids which are depositing in that plaque. And I'll show you a little bit more about that biochemistry next unit. There's a cell that we find inside plaque called a foam cell, and the foam cell is a macrophage which has engorged itself with fat. And they call them foam cells because they look kind of like bubbly. So if you look at that histology, you see some of those cells that look kind of like bubbly. You can see the dark staining pink nucleus, dark staining purple nucleus in these cells, but then you also see more like a clear pink type of vacuole. Those are foam cells, and those foam cells are macrophage, which are kind of sucking up the fat in this plaque and biochemically converting that fat into inflammatory mediators. You guys know who Mr. Bubble is? Mr. Bubble, I remember Mr. Bubble. When I was a kid, I always liked Mr. Bubble. Mr. Bubble soap suds. That, to me, when I saw these cells under histology, it made me think of Mr. Bubble. All right, let's leave him alone. Let's come back to atherosclerosis. So now think of it. Rather than having nice, elastic, smooth muscle, now you're starting to have that overtaken by fat, inflammation, fibrosis, calcification, and that's going to damage that tunica median. It's going to make that vessel less elastic. By being less elastic, you can't vasodilate. When you can't vasodilate, you can't increase blood flow. Another part of plaque is capillaries are going to build up in that plaque. And the capillaries, these small capillaries that build up within the plaque, is referred to as the vasovasorum. That vasovasorum, those vessels within there are not stable, and they're prone to hemorrhage and they're prone to rupture. So hemorrhage and rupture of the vasovasorum can lead to blood clotting and increase in the plaquing. I'll show you that in the next slide here. And again, all inflammation, long-standing inflammation, as we learned, long-standing inflammation leads to fibrosis. So if there's inflammation going on in the plaque, eventually there's going to be fibrosis happening within that plaque as well. And all these different things, fat accumulation, oxidation of lipids, inflammatory response, all these things become targets for treating coronary artery disease, and we'll look at some of those targets as we push on here. Plaque begins setting up the partial occlusion, and if we put thrombus on top of the plaque, then we can fully obstruct that vessel. So look in the upper left here, see all that plaque in the vessel? And now see that hemorrhage within the vessel. Remember that hemorrhage comes from that microcapillary network referred to as the vasovasorum, which in there. If that starts to hemorrhage, and that hemorrhage breaks all the way to the endothelium, remember what starts the clotting process in the blood vessel? It's damage of the endothelium. So damage of the endothelium due to the rupture of that plaque, then we'll start adding thrombus, blood clot on top of the plaque, and that blood clot on top of the plaque can fully obstruct that vessel. If we were looking at the picture on the right, if you took any one of those vessels and put plaque in there, and then on top of the plaque develop a thrombus because of the rupture of the plaque, you could completely obstruct blood flow in that portion of that coronary artery, and then that would lead to myocardial infarction, right? The lack of oxygen delivery to the myocardium, call that a heart attack or myocardial infarction, right? So coronary atherosclerosis can lead to full obstruction of the artery, a heart attack, and you see that in the low left picture there. There's an angiogram, so they're injecting, in the cardiac cath lab, they're going to inject contrast through the aorta into the opening of those coronary arteries and look at the blood flow. So on the left there, you're looking at blood flow going into the right coronary artery, and you can see this abrupt stop, right? There's no flow beyond that block. 100% obstructed, that's going to lead to a heart attack. And then you can see how that artery has been reopened after whatever intervention they did there in the cardiac cath lab. And the upper portion, then you can see a stenotic lesion that looks like that's coming in the left anterior descending artery, right? You can see that area that's narrowed down, and that narrowing down is going to be due to plaque. So coronary atherosclerosis can present as narrowed down stenotic lesions, which is decreasing O2 delivery, and that's going to be problematic when there's a need for increased cardiac demand, right? An individual starts participating in an activity that requires more cardiac output, but you can't increase the cardiac output because you're unable to get increased blood flow to the heart through those coronary arteries, right? So you develop cardiac ischemia where the supply doesn't meet the demand. And what's the primary symptom of diminished O2 delivery to the myocardium? When O2 supply can't meet the demand, what does the patient start to experience? You got it. Shortness of breath and chest pain, angina. So we'll look at angina here as we move on. So again, partial occlusions and complete obstruction. The partial occlusion is typically due to the plaquing process. The full occlusion due to the accumulation of thrombus on top of the plaque. All right, so angina and chest pain. Remember, all chest pain is not from the heart. I'm sure you personally have experienced chest pain, which was not angina, and I know that you've seen patients who've had chest pain, which it wasn't angina as well, right? Think of the pleuritic chest pain that someone might get from pneumonia, or chest pain that someone might get due to inflammation or athletic overuse syndrome, whatever, right? All chest pain is not from the heart. So what we want to be able to differentiate is, what does chest pain from the heart look like? Or what's the patient, how does the patient describe that chest pain, right? So initial symptoms of coronary artery disease, patients typically complain of chest pain, fatigue, exercise intolerance, and shortness of breath. And some people have atypical presentations where they have silent coronary artery disease. They've got no symptoms of that. But the most common symptom of coronary artery disease is angina. And angina is a descriptive term that we give to the typical type of chest pain experienced by an individual with coronary artery disease when O2 supply doesn't meet the demand. And that pain is typically described as squeezing or constrictive or a heavy sensation. I know for those of you who have been working in cardiology and emergency medicine and critical care, and those of you with a lot of experience have seen numbers of individuals, and probably on a daily basis, right? A lot of you are probably seeing individuals who have that classic description of angina with fatigue, exercise intolerance, and shortness of breath, right? So we have individuals who have stable angina, meaning that their angina is due to exertion, it's predictable, and it's quickly reversed with simple interventions such as resting or maybe nitroglycerin, which we'll talk about. We have individuals who have unstable angina where it's no longer predictable and it's getting worse and it suddenly occurs, and it may come on even at rest, where exertional activity is not needed to bring it on. It just kind of comes on. And then we have individuals who have an actual myocardial infarction where there's been complete obstruction of oxygen to the heart muscle. And the lack of oxygen to the heart muscle can lead to rapid ischemic death of the myocardium to both conduction cells and contractile cells, right? Again, both types of cells are O2 dependent. So coronary artery disease can manifest silently. Atypical people have no idea that they have it. It can manifest as stable angina. Again, that is chest pain which is predictable and typically easily manageable. And then we have unstable angina, and then we have myocardial infarction. And that myocardial infarction can be broken down two different ways: non-ST segment elevation myocardial infarction, that typically is involving ischemic injury just to the subendocardial or subendothelial layers of the heart. And then we have ST segment elevation MI or STEMI, where there's complete loss of blood flow to the myocardium, and now we're getting ischemic injury across the entire wall of the heart. So underneath that dotted line, we refer to that as acute coronary syndrome, ACS. And when an individual has ACS, we want to be able to differentiate it as being unstable angina, non-ST elevated MI, or an ST elevated STEMI, ST segment elevation myocardial infarction, STEMI. Reviewing again, symptoms of coronary artery disease can be anything from stable angina, unstable angina, to infarction, all the way to sudden death, right? Typical symptoms: crushing chest pain, feeling of doom, difficulty breathing, shortness of breath, exercise intolerance, tachypnea and tachycardia, diaphoresis, looking pale. Some individuals will have left arm, left shoulder pain. Some individuals be nauseated. And then there's a select group of individuals who may have silent coronary artery disease. They have no symptoms. Usually think of those individuals as being a ticking time bomb. They're walking around with significant coronary atherosclerosis, but they have no idea because they're not developing those typical exertional symptoms such as squeezing constrictive chest pain with fatigue and sweating and shortness of breath. One of the discussion threads that I have in Blackboard this week for you to chime in on is discussing a person that you had who had asymptomatic coronary artery disease. They had no idea that they had coronary artery disease until some catastrophic event happened, or they had a cardiac cath and, oh, look at this. Look at all this plaque that you have. So that's one of the threads that I've got that you can select in this week's Blackboard discussion. Normal artery, an artery showing some minor plaque where you would expect the individual to be relatively asymptomatic. An individual with significant plaquing in that artery, that individual more than likely will be experiencing angina. That angina may be chronic and stable, so that person knows, okay, I know that every time I walk up 2 flights of stairs, I'm going to start having some chest pain, feel a little short of breath. I got to sit down, maybe do an intervention like a sublingual nitro, and they get better. And then full-on heart attack, you got a plaque with thrombus on top of it, and that completely disrupts blood flow to the myocardium. That's going to be your heart attack or your myocardial infarction. Okay, let's think of this nice man here. Let's call him Frank. Frank only gets angina with strenuous activity. He becomes fully asymptomatic with 1 nitroglycerin. So he's already been seen by his internist or family practitioner. He's been referred through a cardiologist, and we know that he's got some chronic stable angina. All right, today he's sitting and reading the paper and suddenly has an onset of chest pain. He's feeling squeezing, constrictive chest pain, feeling nauseated, sweating, short of breath. He takes his first nitro, it doesn't get better. He takes his second nitro, it's still bad. Still feeling short of breath and sweating. Should we still label Frank as having stable angina? Absolutely not, right? His angina came on at rest. It wasn't predictable, and his angina is no longer being manageable. The simple intervention that he was doing is no longer working. In fact, it's getting worse. So now we're going to say Frank has acute coronary syndrome, and now we have to differentiate this as unstable angina versus an actual MI. And if it were an MI, is it the non-STEMI or is it the ST segment elevated MI? Where the STEMI is the worst of it all, where again, you've got ischemic injury, you've got transmural or ischemic injury across the entire wall of the myocardium. So what do we do to differentiate acute coronary syndrome? How do we tell if what this individual has is unstable angina versus an MI? There's some invasive and non-invasive things that we can look at, right? A lot of you guys do this on a daily basis. We can look at cardiac enzymes. We can look at 12-lead EKGs. We can take this individual to the cath lab and have a cardiologist actually look at the arteries themselves and look for segments of occlusion or obstruction. And then we can also do things like echocardiograms or cardiac MRIs and look at wall motion and determine whether or not there's been, usually this is looking for an older infarct or the consequences of an infarct, looking to see if there's any isolated segments of wall motion abnormality because we killed the portion of a ventricle due to obstruction due to lack of blood flow. So we got a number of different things that we can do here to help differentiate acute coronary syndrome. So myocardial infarction, really quickly, let's just talk about this pathophysiology. A myocardial infarction is going to occur when there's a prolonged interruption of coronary blood flow leading to a lack of oxygen and nutrients to the myocardium. Those myocardium cells are going to die because they've only got so long that they can live without a steady supply of oxygen. The death of those myocardial cells, the term for that would be myocardial necrosis. How much occurs is all dependent on how extensive that obstruction is in terms of severity and extension and duration, right? A full occlusion for a long duration is going to be pretty problematic in terms of the ability of inducing myocardial necrosis. So let's assume that there's no blood flow. Let's say we got someone with plaque and now there's a clot on top of it. What begins happening in those first seconds, the tissue is going to get ischemic. Without the lack of oxygen there, those cells are going to shift from aerobic to anaerobic metabolism. That's going to start to result in an accumulation of hydrogen ions, potassium ions, loss of ATP and glucose. And that cell now is going to start to break down due to ischemic injury. Go on longer now, and more biochemical processes are going to happen, which is going to result in inflammation, necrosis, and eventually scarring of that myocardium, right? So the initial ischemic damage followed by inflammation. That inflammation can lead to outright necrosis. And if the incident is survived and O2, if the incident is survived, eventually what can happen is scarring within the myocardium. And it's the scarring in the myocardium that can lead to wall motion abnormalities. If you scar that myocardium with a fibrous scar and you don't have muscle there, that segment of the wall isn't going to contract properly, and you usually can see that on things like echocardiograms or cardiac MRIs, right? So we're going to have acute complications, delayed complications, and for an individual that does not survive a heart attack, we can certainly see post-mortem findings of an MI. So this, if you type in this URL, you can get to a nice review article from Medscape, and this does a nice review of some of that biochemistry and inflammation and gross pathology, which is happening in an MI. I went through it kind of very cursory, but I kind of want to show you some of these post-mortem complications so you understand what I mean when I'm talking about transmural injury and what I mean when I talk about scarring and necrosis. So if you look at these three hearts here cut in cross section, where the left ventricle size is the larger size and the right ventricle is kind of like the smaller, thinner region. Look in the first picture on the left, you can see transmural necrosis, right? You can see that big infarct that goes across the entire left ventricular wall and leads to necrosis. That was more than likely a fatal event, right? Then you can see a couple of hearts here that has a lot of scarring all around different regions of the ventricle, where that scarring kind of looks grayish white. Doesn't look like that nice, healthy, reddish myocardial muscle, right? So those are older infarcts, and you can see that all pointed out in the middle picture and the right picture. Small infarcts, or infarcts which are survived, can lead to long-term pathology to ventricular conduction. Impaired conduction is an important mechanism that can lead to heart failure. Heart failure, I think of heart failure as poor contractility of the heart. One reason that we can have poor contractility of the heart might be due to post-MI or recurrent myocardial ischemia, small MIs, subendocardial MIs, etc., right? And you can see that we can end up with this myocardial scarring. There's another term that I want to look at that talks about myocardial remodeling as a consequence of hypertension, as a consequence of ischemic injury. Here is myocardial remodeling. So the ventricle is actually changing in size and shape and function, and that is something that can happen following ischemic injury. It is also something that can happen due to long-standing hypertrophy, long-standing hypertension. And what it results in is myocardial hypertrophy, muscle hypertrophy. So muscle hypertrophy may be okay for athletes and weightlifters. There's a picture of Arnold, right, when he was young. That's muscle hypertrophy. But hypertrophy of cardiac muscle is not necessarily a good thing. You know, building up muscle as an athlete, muscle hypertrophy for athletics and, you know, general conditioning and well-being, you know, that's okay. But you don't really want your myocardium to get hypertrophic. Hypertrophy of the myocardium leads to loss of compliance, leads to loss of elasticity, and that can impair both ventricular filling and it can impair ventricular relaxation. You need a nice compliant ventricle which can expand and contract to get good cardiac output. Myocardial injury due to hypertension, myocardial injury due to ischemic injury can lead to hypertrophy, and that hypertrophy leads to impaired contractility. Too much muscle in the heart also increases O2 demand of the heart, and that can also be problematic for an individual with long-standing coronary artery disease. An individual with long-standing coronary artery disease, you want them to be utilizing less O2 demand. Why? Because if they've got fixed coronary artery lesions, it's going to be tough for them to get more O2 into the myocardium, right? Because of the lesions can't, right? You can't get blood flow through those stenotic lesions. So myocardial hypertrophy, outright scarring and fibrosis, or outright microscopic histologic hypertrophy is problematic in terms of post-MI complications or long-standing complications of hypertension or coronary artery disease. And in the histology there on the left, you can see what normal myocardial cells look like in terms of size, and then you can see what a hypertrophied myocardial cell looks like. And again, we don't want hypertrophy. All right, now let's get back to differentiating acute coronary syndrome. The three types of, what are the three components of acute coronary syndrome: unstable angina, non-STEMI MI, and a STEMI MI. So one way we can do that is we can look at cardiac enzymes, particularly troponin levels. So again, so there's a nice picture of some nice normal myocardial cells and their arrangement, right? They got that arrangement of those protein filaments, the actin, the myosin, the troponin, the tropomyosin. All those proteins are intracellular. Now, if the cell dies due to ischemic injury, right? So ischemic injury can lead to necrosis of those cells. The necrosis or breakdown of those cells is going to result in the release of those, result in the release of intracellular contents such as acids and proteins and enzymes. And some of those proteins that get released are the cardiac enzymes, specifically troponin. So in an individual then who develops ischemic injury, myocardial necrosis, release of the intracellular enzymes, what happens to the enzymes in blood? Or where do those intracellular proteins go when the myocyte dies? Those intracellular proteins end up free floating in blood, and then we can assess that with the blood test by looking at specifically enzyme levels such as troponin. So a lot of enzymes can be released when cells die, but the ones that we're looking for, those that are most specific for the cardiac muscle, are going to be our cardiac troponin enzymes. We can see that there's a lot of other things like CK and AST and LDH and glycogen phosphorylation, BB. There's a number of different proteins and enzymes that can be released due to ischemic injury, but the ones that we are most interested in, those which are most specific, the best markers are going to be the assessment of the troponin levels, okay? And here is a graph showing you how quickly some of these enzymes elevate and how long those enzyme levels can stay elevated post-myocardial injury. So if we assume that the ischemic injury occurred at time 0, we see that the most rapidly elevating enzymes are both the troponin T and the troponin I, right? So troponin T and troponin I elevate early. They're the most sensitive with respect to cardiac injury, so troponin levels become very critical in assessing an individual with acute coronary syndrome, right? Troponin levels going up means that, excuse me, troponin levels going up means that we have sustained an ischemic injury to the myocardium. And then you can see other enzymes will elevate as well, but it's the troponin levels that we want to see elevated as helping us confirm whether or not this individual is having an MI. You got to be careful. One assessment alone doesn't tell you yes or no. So very often, for those of you who do this in the emergency department and internal medicine, cardiac medicine, you know that it's usually serial troponin levels that you're looking for a rise in those troponin to help you make that determination whether or not there was an MI. Another important portion of looking at coronary syndrome is the 12-lead EKG. So the 12-lead EKG is all about looking at myocardial electrical conduction. Remember, ischemic injury affects the conduction cells and the contractile cells. So the contractile cells, when they die, they're releasing those enzymes, particularly troponin. When the conduction cells get adversely affected, we see changes in the electrical activities of the 12-lead EKG. And we'll look at the EKG in a little bit more detail in Unit 2, but one area of the EKG which is highly sensitive, or maybe say most sensitive to ischemic injury, is the ST segment, right? So that segment between the QRS and the T wave. If you remember, the QRS is when the ventricle is contracting systole, and the T wave is when the ventricle is relaxing diastole. So in between there, we have that ST segment. That ST segment usually sits on a baseline. Elevation of that ST segment or depression of that ST segment can be a nice marker for myocardial ischemia. So here we got 4 PQRS complexes. Look at the top segment where you can see, look at the top one where you can see the ST segment is at baseline, right? You can see in the next one where the ST segment has been elevated, so ST elevated MI, that'd be indicative of a STEMI. You can see ST segment depression, non-STEMI, indicative of myocardial ischemia. And another thing that you can see that may be indicative of ischemia is an inversion of the T wave. Usually the T wave deflects upward, inversion, downward deflection of the T wave may be due to ischemia. Not inverted T waves may be due to a number of different things, including electrolyte abnormalities, but it can also be indicative of myocardial ischemia. So non-invasive means of looking at acute coronary syndrome, looking at troponin levels, looking to determine if we have rise in troponin levels, and then looking at the 12-lead EKG and looking for those ST segment elevations and depressions or T wave inversions indicative of myocardial ischemia. So I'm going to really quickly, I'm just going to show you 3 EKGs here, and what you're going to do for me is you're going to determine, is the patient having an acute STEMI? So let's assume in each of these 3 EKGs, you've got an individual who now has sudden onset shortness of breath and squeezing constrictive chest pain. You've drawn bloods for troponin levels. You're waiting for those to come back. You do a rapid 12-lead EKG. So here's patient 1. Are they having a STEMI? Can you see it and can you localize it? Here's patient 2. Are they having a STEMI? And here's patient 3. Are they having a STEMI? Okay. So I will give you one 12-lead EKG on the quiz, and on the bigger exam, we're going to have you look to identify the STEMI. Those of you who do this every day, you probably do this in your sleep, you can pick this out. Those of you who have a little bit less experience in cardiology, you may have to look at this a little closer, and if you need some help with that, ask out in the discussion boards or send me an email, and I'll try to find some more EKGs that I can post up for you to practice with. I want you to be able to recognize the STEMI, okay? I'm not going to be so subtle in giving you an EKG that's got a little bit of ST depression, but the STEMI, I definitely want you to be able to recognize that, okay? So there's 3 that you can take a look at, and I'll try to get some more up on Blackboard or in the discussion threads. And then you know by the 12-lead EKG, based on where you see the ST segment elevation, you can localize where in the heart is that obstruction or is that infarction occurring. Is it right-sided versus left-sided? So an anterior MI, a septal MI between the right and the left, right in that septum between the right and the left ventricle. Anterior MI and septal MI, they're, anatomically that's very similar. Lateral MI around around the lateral or inferior surface of the left ventricle, and an inferior MI, particularly on the right ventricular side of the heart. And you can look at your 12-lead EKGs and look in which leads you see the ST segment elevation and determine, is this right-sided or left-sided, and then get an idea, is this coming from the left coronary artery versus the right coronary artery. So in addition to seeing the STEMI, I would also like you to be able to determine, is it primarily right-sided or primarily left-sided? And then on the left side, do you think it's primarily anterior, or do you think it's primarily lateral? The lateral MI is the left circumflex. The anterior MI is the left anterior descending. In this graphic here, they're referring it to AID, anterior interventricular, but that's also left anterior descending. All right, so can you pick up the STEMI? And can you tell me, is it right or left? And if it's left, can you tell me if it's anterior versus lateral? So that's, I believe that's just like the basics of ischemia that you should be able to do with respect to a 12-lead EKG. And if you don't have experience with that, ask out on the discussion boards or send me an email, and we'll help you out with it, okay? All right, so an MI most commonly occurs due to plaquing and then thrombus on top of the plaquing. Remember, when coronary blood flow, when O2 supply doesn't meet the demand, the individual has symptoms of angina. And we talked about what are the characteristic symptoms of angina. When coronary blood flow is fully obstructed due to thrombus on top of plaque, that's when a myocardial infarction, particularly the STEMI myocardial infarction, occurs. Now, we think of coronary artery disease in middle-aged and elderly adults who have risk factors and unhealthy lifestyles, smoking, non-compliant diabetes, overweight, sedentary lifestyle, etc. Classic risk factors for coronary artery disease. But can a young, healthy individual with clean coronary arteries develop an acute myocardial infarction? And I believe most of you know that the answer to that is yes. How does that happen? How do you get a myocardial infarction with clean coronary arteries? The reason that happens is when you get intense vasospasm or intense vasoconstriction of the coronary arteries. Remember, when any artery constricts, you get decreased blood flow through that artery. If you get intense vasoconstriction in a coronary artery, you're not going to get adequate blood flow to the myocardium, and that can lead to angina, and that can lead to both non-STEMI and STEMI myocardial infarction. So what leads to this intense vasospasm in young adults? It's usually drugs, usually stimulant drugs. Any drug that has vasoconstrictor properties to it can constrict coronary arteries and lead to sudden myocardial ischemia. And for those of you in cardiology and emergency medicine, you have seen young adults who do cocaine and methamphetamine and even Adderall and other stimulants and get that vasoconstrictive effect that leads to MI. I'm sure a number of you have seen that. I put that up as a discussion thread, so if any of you have seen a young healthy adult develop acute coronary syndrome or MI due to intentional recreational drug abuse, then we'd like to hear a little bit about that on that discussion thread. There was a dietary supplement that was readily available over the counter. It was called ephedra, or the Chinese name was Ma Huang. And that drug was used primarily for athletic performance. There were a lot of athletes that were using this to increase performance. There were people that were using it as a stimulant. It helped them do that. As a stimulant, people were using it for weight loss. And as a stimulant and vasoconstrictor, people are also using it as a sex aid. And what happened in the 90s, after this drug was, it was protected by the Dietary Supplement Act of 1992. So this drug was readily out there and available. And what started happening is young adults were dropping dead due to their use of Ma Huang. And what was happening is they were developing both MIs and strokes due to the intense vasoconstrictive action of that drug. I personally saw a couple of teenagers with MIs and a couple of teenagers with cerebral ischemia due to use of Ma Huang. And as I recall, in all of those cases, it was either somebody using it to try to lose weight or a young athlete trying to use it for enhanced athletic performance. So careful with these stimulant drugs. All these stimulant drugs have some alpha-1 property to it. Remember, alpha-1 causes vasoconstriction, and intense vasoconstriction can lead to profound ischemia, particularly myocardial ischemia. Ephedra now is banned. You can't get it over the counter, but it's still available, like heroin, right? You're not supposed to be able to get heroin, but it doesn't take too much effort to find heroin. It doesn't take a whole lot of effort to find ephedra. So in terms of dietary weight loss supplements, the FDA says you can't have ephedra in it, but you can go to the internet and still find ephedra containing products from other countries that you can get here into the US. So don't use it, don't have your patients using it. Counseling anybody who's trying to look for a weight loss product, this is not the one to use. This is extremely dangerous product. All right, again, a little bit pharmacology and drug abuse stuff for you. I had to get that in. Mona Lisa. I can't sing, so I'll stop singing for you. The Mona Lisa. Love that photo, huh? So why do I have the Mona Lisa here in our discussion about ACS? Because, again, for those of you with experience, you know about monotherapy. So what is monotherapy? Morphine, oxygen, nitrates, and aspirin. The initial intervention for an individual having diagnosed or suspected acute coronary syndrome. What we want to do is we want to restore O2 supply to the myocardium so our supply now can meet the demand. For big interventions, morphine, relieve pain and anxiety. That in and of itself is going to decrease myocardial demand, but morphine's got some vasodilator properties to it that should help us increase coronary artery vasodilation and increase blood flow into coronary arteries. O2, right? Anybody suspecting of having symptoms of myocardial ischemia ought to be put on supplemental O2. Nitrates, we're going to look at terms of how nitrates work in relieving angina and ACS. We want to be using the fast-acting nitrates, so either the nitrates that we give sublingual or the nitrates that go on skin. There are oral nitrates that are used for angina prophylaxis, and I'll show you the difference between those in a minute here. And then aspirin. Remember, we talked about platelets initiating the coagulation event, myocardial infarction is due to thrombus on top of plaque. We want to inhibit that thrombus, and one of the immediate ways of doing that is to inactivate our platelets. So giving the individual an aspirin when they present with ACS to immediately take out the platelet function. If we turn off our platelets, then we make it less likely that we're going to be able to keep accumulating and building that thrombus up in those coronary arteries. Vasodilation is extremely important. Vasodilation is important in the treatment of ACS, and vasodilation is important in the treatment of hypertension. So mechanistically and biochemically, how can we get to vasodilation? So let's just do this really quickly. Sorry about the biochemistry here, but I want you to see this so it makes the drugs a little bit better for you to understand. The top of the page, the top of this graphic is the lumen of the blood, so blood is moving through there. Then you see the endothelial cells. Those are kind of like those oblong slanted cells. And then underneath the endothelium, you got the bigger, fatter, oval, smooth muscle cell. And you want that smooth muscle cell to relax, right? So when it constricts, calcium moves into that muscle cell, and then calcium drives a reaction on myosin to cause myosin to contract, and that causes vasoconstriction. That vasoconstriction is reducing blood flow. What we want that what we want that smooth muscle cell to do is relax and stop contracting so we get vasodilation and increased blood flow. So endogenously, we vasoconstrict through calcium, but endogenously, we vasodilate through a product called nitric oxide, NO. And in the endothelial cells break down the amino acid arginine into nitric oxide. Nitric oxide diffuses out of the endothelial cells into the muscle cell, and then nitric oxide stimulates an intracellular component called cyclic GMP, and cyclic GMP now inhibits myosin so that now the muscle goes into relaxation or vasodilation. So the alpha-1 receptor increases calcium, and that calcium causes vasoconstriction. So a couple ways now that we can get to vasodilation mechanistically is by blocking the calcium ion channel, right? So calcium blockers block that ability to get calcium into the muscle, into that smooth muscle. That will inhibit contraction, therefore we get less vasoconstriction, more vasodilator. We can use alpha-1 receptor blockers like terazosin, prazosin, that works too. So calcium channel blockers and alpha-1 antagonists are one way to get to vasodilation. Another way to get to immediate vasodilation is to enhance the cellular content of nitric oxide. Remember, normally the endothelium releases nitric oxide. That stimulates cyclic GMP, and that leads to vasodilation. So pharmaceutically, one way that we can get to vasodilation is by providing the individual a drug which is going to give them nitric oxide, and that's the way our nitrates work. There's our nitric oxide in the blue circle. There's our calcium ion channel in the red circle. Okay, calcium channel antagonists, primarily used for hypertension. They don't really have a lot of use. You don't see them in monotherapy. So an individual with acute coronary syndrome may not get a calcium channel antagonist, but long-term, to prevent vasoconstriction and enhance vasodilation, they could be on a calcium channel antagonist. So you can see a number of calcium channel ion antagonists. And you're probably most familiar with amlodipine and nifedipine. Those are probably the two most common calcium channel antagonists that are there. Again, potent vasodilators, and they help a lot with inhibiting vasoconstriction. They're useful in the management of hypertension. They don't really come into play a whole lot immediately in terms of monotherapy. What we want with monotherapy are the organic nitrates, all right? So we have nitroglycerin as our fast-acting nitrate, and we have isosorbide dinitrate as our long-acting prophylaxis nitrate. And when you look at both of these molecules, you can see that those molecules each have nitric oxide, NO, as part of their chemical structure. When we give the individual these drugs, serum enzymes break down that drug to release the NO, and then that nitric oxide becomes the source for the smooth muscle to increase cyclic GMP and lead to vasodilation, thus increasing blood flow. Nitroglycerin itself has got really poor oral bioavailability, so you can't take it oral. So the way that we take it is either sublingual, placing it in the mouth as a tablet or a spray, then it absorbs through the oral mucosa, or we put it on the skin in the form of a paste or a patch, and then it absorbs through the skin. So in terms of monotherapy, we want a fast-acting nitrate. The sublingual and the dermal nitrates in the form of nitroglycerin serve that role and allow that individual to get that exogenous nitric oxide. The isosorbide tablets then are used, usually those are once a day extend-release tablets that the person takes, and it's more of a prophylaxis for angina, where the nitroglycerin itself is what comes into play with MONA, okay? So that's worth understanding. That's nice to see how that mechanism of action works. All right, so much more that we could have been said about atherosclerosis and MI management, and we didn't even talk about cardiac catheterizations and angioplasties. But again, this course is mostly to talk about pathophysiology, so I think we did do a good job at covering risk factors and what's the components of that plaque and how that plaque can change some of the physiologic dynamics, the role of vasodilation, and then the complications with respect to hypertrophy and remodeling. So, and again, we've got somewhat limited time in terms of how much. I'm not going to make these PowerPoints, 5 hours long. We're already pushing 2 hours here, and we got to cover some stuff on heart failure. So let's just keep going through this and finish up with a discussion on heart failure, then that will wrap up cardiac 1. All right, so a big equation here. Cardiac output equals heart rate times stroke volume. We're going to be talking about rate. Next week, we're going to talk a little bit more about filling pressures. Next week, resistance pressure or hypertension. We spent a little bit of time talking about. Right now, wrap this up, let's talk about contractile forces, or what is driving the ventricles to actually pump and eject blood out, and how that might fail and lead to cardiac muscle pathology, or cardiomyopathy. So cardiac output equals heart rate times stroke volume. The blood ejected in 1 minute is equal to the number of beats per minute times the amount of blood ejected in each beat. So if this individual had a heart rate of 75 and each time ejected 75 milliliters of blood multiplied together, that person's cardiac output would be 5.2 liters per minute. So let's look at some numbers that would be representative of a healthy adult. So 70 kilogram adult ventricle fills with about 135 mLs of blood and ejects 75. So what I'd like you to do now is fill this in. What's the end diastolic volume? What was the stroke volume? What's the end systolic volume? And then calculate the ejection fraction and see if you get a normal ejection fraction. Again, a normal ejection fraction at rest is about 50 to 55%. And then remember, cardiac output always has to meet the metabolic demand for oxygen. It's never fixed. It must be able to change. All right, why might the myocardium fail, or why might the cardiac contractility be impaired? Most common cause in the US is coronary artery disease. Remember, ischemia of the myocardium is going to impair both conduction and contraction. An ischemic disease of the myocardium is going to be the major reason why individuals develop heart failure. A lot of other causes of heart failure: alcoholism, chemotherapy. Those of you in oncology know that certain drugs that you use can lead to long-term congestive heart failure. Nutritional deficiencies, infections. Those of you in pediatrics understand congenital malformations and how that can lead to heart failure. We'll do a little bit of that in Unit 2. Long-standing hypertension, obesity, hyperthyroidism, go on and on. Numbers of different things that can lead to heart failure. We're primarily going to focus on congestive heart failure due to coronary artery disease in this unit. So heart failure can be long, chronic, slowly worsening, begins with mild symptoms that progresses. Good example of that would be dilated congestive cardiomyopathy, the most common cause of heart failure in the US. Sometimes heart failure can start rapidly and progress rapidly. You need extreme measures to then optimize cardiac contractility. Typically what we see in individuals who become septic develop myocarditis, develop profound hyperthyroidism. And then we have some forms of heart failure that can be relatively silent, where there's anatomic pathology, the individual is relatively asymptomatic, and then suddenly they have a complete collapse of contractility and sudden death. And this is something that we see in young athletes due to hypertrophic cardiomyopathy. So we'll cover all three, but we'll spend most of our time talking about congestive dilated cardiomyopathy. Normal hearts on the left and congested cardiomyopathy on the right. So if you look at this in the normal chest x-ray, dilated cardiomyopathy, now you see a big dilated heart with increased markings in the lungs indicative of pulmonary edema. In the normal heart in the middle, the yellow bands show you that nice amount of healthy ventricular muscle. In the pathologic side, you can see how that muscle has been really thinned out. So see how the ventricular cavities are really, really big and dilated, and the amount of muscle there is very small. So very small amount of muscle, going to have weak contractile forces. And then you can see that in the lower picture too, where you do a cross section. Look at the thinner right side, the more thicker left side. And then you can see that healthy muscle versus on the right side where you see kind of like that big dilated cavities with really, really small amount of muscle surrounding the cavity. So dilated congestive heart failure or dilated cardiomyopathy. What leads to this progressive dilation of the heart and this progressive accumulation of fluid in the body, particularly in the lungs, leading to pulmonary edema? Well, the problem goes back to the renin-aldosterone system. You have an individual who starts to develop poor perfusion due to heart disease. Poor perfusion then is a stimulus to activate renin and aldosterone. So the heart begins, for whatever reason, the heart starts to pump less effectively. And perfusion, lack of perfusion to the kidney is sensed as a result. The kidney then activates renin and aldosterone, and the goal of that pathway, as you've seen, is to increase blood pressure through vasoconstriction and begin conserving sodium and water. And that is the last thing that you want to do to a failing heart. So if a heart is already having poor contractility, you do not want to hang on to more sodium and water, and you don't want to increase vasoconstriction because that's only going to make matters worse. And now you're going to end up in this cycle where poor perfusion leads to sodium and water retention. Sodium and water retention leads to dilation of the heart. Dilation of the heart further decreases perfusion, leads to more sodium and water retention. And now you're in this vicious cycle that leads to cardiomegaly, increased size of the heart, and the impaired perfusion is going to lead to backup of blood flow. And when the left ventricle starts to fail, that blood flow is going to back up into the lungs, leading to pulmonary edema. And we can see that progressing here in these x-rays from the normal heart without any evidence of pulmonary edema to a heart that's starting to enlarge with a little bit of increased markings in the lungs, a little bit of fluid and pulmonary edema, to now a markedly dilated heart with marked pulmonary edema. And the pulmonary edema that you're seeing is all that white excessive vasculature. You see what I mean? Look at the difference between the photo on the left and the photo on the right, and you can see that progression happening. So go back to that Frank-Starling curve, and we said, remember, in a normal heart, the more blood that you put in the heart, the more you fill the heart, the better becomes the contractility, and you get an increased stroke volume. If you have a pathologic heart, that's not going to hold true. More fluid retention is actually going to eventually lead to less stroke volume, and then eventually that curve is going to fall downward and to the right. So in orange there is the classic Frank Starling curve for a failing heart. And again, the number one reason for a failing heart, so impaired contractility, number one reason in the USA, again, is coronary artery disease leading to dilated congestive cardiomyopathy. And here's that endocrine response again to inadequate contractility or inadequate perfusion. As soon as the heart begins to fail for whatever reason, as contractility goes down, perfusions of organs go down. That sense in the kidney, and that inadequate perfusion is going to initiate the renin angiotensin II aldosterone response that will result in the retaining of sodium and water in vasoconstriction. That retaining of sodium and water in vasoconstriction is actually going to make cardiac contractility worse. And now we're going to be in a vicious cycle where impaired perfusion is going to lead to further activation of that renin angiotensin system. So we're building up angiotensin II, which is the protein. So the structure of angiotensin II is shown on the left. We're building up aldosterone, that's a steroid that's shown in the middle. And the results of those two is going to be vasoconstriction, sodium and water retention. Now, luckily, we have an endogenous peptide, natriuretic peptides, and the abbreviation of this is BNP. This is an endogenous means to counter excessive sodium and water retention. We'll talk about what BNP does on the kidney. BNP protein actually acts as an endogenous vasodilator and an endogenous diuretic. So it's our own self-built-in means to deal with fluid overload. BNP will be released, and that BNP will try to compensate for that excessive sodium and water retention. Natriuretic peptides, we have ANP from the atria, we have BMP from ventricles and also from brain. And these are small proteins that are released in response to volume overload, and they enhance diuresis and they promote vasodilation. And both enhanced diuresis and vasodilation are beneficial, and they favor the heart in states of dilation and congestion. The newest drug on the market for treating congestive heart failure, Entresto, utilizes this mechanism. And we're going to talk a little bit about Entresto when we get into the section talking about how do we pharmaceutically manage congestive heart failure. So again, there's a lot of different etiologies of heart failure. For whatever reason, when the heart starts to fail, sympathetic and endocrine responses kick in. They sense that hypoperfusion, and that hypoperfusion leads to sodium and water retention. And that sodium and water retention is what's going to lead to the progressive dilation of the ventricular cavities, the thinning out of that muscle, and weakened contractility. And suddenly now blood flow is not going to be effective, and it's going to start to back up and accumulate. And again, when the left ventricle fails, that's going to lead to pulmonary edema. When the right ventricle fails, that's going to lead to body edema, such as liver edema, lower extremity edema, etc. And we're going to talk about all these targets in there to decrease sodium and water retention. So in that failing heart, As you can imagine, we need to get rid of sodium and water, so we're going to talk about how these drugs do that. Okay, congestive heart failure, again, inadequate pumping of blood, typically involves all chambers and both sides of the heart. Some people may have a left or a right-sided predominant type of heart failure. Heart failure almost always involves the systolic components, meaning there's inadequate ejection of blood, but we can also have diastolic heart failure where we have inadequate filling of the ventricles. So sometimes we see that as a component of heart failure. When blood can't pump through the heart, then blood's going to back up. So again, a failing left heart results in fluid accumulation in the lungs, pulmonary edema, and a failing right heart leads to fluid accumulation in the body, particularly in the liver and in the legs. And the severity of the cardiac impairment determines how severe the individual's symptoms are going to be. And it could be something such as inhibiting, it could be mild symptoms where they only have symptoms during exercise, so they develop exercise intolerance, or the heart failure can be so bad that it impacts adversely their normal daily activity, or ADLs, activity of daily life. And you see this in heart failure patients. Some people are only symptomatic during exertion, other people's are symptomatic even at rest, therefore impairing their ability to do simple daily activities such as cook, clean, etc. All right, symptoms of heart failure. Pulmonary edema due to left-sided heart failure. Individual is short of breath. Congestive cough, they might be coughing up foamy sputum. When you listen to their lungs, you hear decreased breath sounds and the characteristic crackles of pulmonary edema. Failing of the right heart results in fluid accumulation in the body that can manifest as jugular venous distension, hepatomegaly, ascites, accumulation of fluid in the abdominal cavity, and pitting edema, most commonly in the lower extremities due to the effect of gravity. So clinical signs of heart failure: pulmonary edema, RALS, JVD, hepatomegaly, ascites, and pitting edema of the lower extremities. When you listen to the heart, you may hear what's referred to as a characteristic gallop, an extra sound. So remember, listening to the heart, you got S1, S2, dun, 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 dun. In heart failure, you may hear a gallop rhythm such as a dun, 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 or a dun, 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 right? S1, S2, S3, or S4, S1, S2. The S3 sound comes at the end of systole, the S4 sound comes at the end of diastole. And they talk about these two states, Kentucky and Tennessee, and if you say it right, it mimics the heart tone, the gallop. So Kentucky, 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 where the E is the S3. Kentuck, S1, S2, E, S3. Kentucky, Kentucky, Kentucky. And in Tennessee, 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 Tennessee. 10 is the S4, SC is the S1, S2, Tennessee, Tennessee, Tennessee. That's the S4 gallop. So these gallop rhythm, these gallop heart tones you can hear in an individual with heart failure. Takes practice. You got to really listen. Takes practice to do that. Once you hear it and you get it, you go, oh, I got it. It sounds so cool. All right. So S3 and S4, both gallop rhythms that can be indicative of heart failure. And our friends to the north, they don't like to use Kentucky and Tennessee, so they use Montreal, Montreal, Montreal as the S3, and Toronto, Toronto, Toronto as the S4. I'm not kidding you, seriously. Go look at that Canadian Medical Association journal, and they talk about how you should use Montreal in Tennessee. If you say that, if you pronounce that right, then the S3 Gallup sounds like the proper pronunciation for Montreal, and the S4 Gallup sounds like the proper pronunciation of Toronto. Go figure, huh? Anyways, I thought it was kind of funny to see that. As you're thinking about that, person in heart failure, think about what will be the effect on the activities of daily life and exercise tolerance. What type of chest symptoms might they have? What might you hear in the chest? What might you feel when you palpate their abdomen, particularly their legs, particularly their liver? Palpate their legs. Palpate their liver in their abdomen, and then look at their legs, and what might you see in their legs? What might you see in terms of neck veins? How will their ejection fraction be affected? What will their cardiac output look like? Here's a thought one. What happens to their BNP levels? So remember, BNP is trying to counter that. So is the heart going to release more or less BNP? You're right, release more, so BNP levels will go up. Poor perfusion of the kidney will result in increased serum creatinine levels. We'll talk more about the kidney in 2 units from now. And then again, chest x-ray. Can you recognize congestive cardiomyopathy and pulmonary edema on a chest x-ray? Dependent then on the degree of symptoms and dependent on the anatomical degree of pathology, then we can classify that individual's severity of heart failure. This is called the New York Heart Association classification of heart failure, and it classifies individuals based on their function and based on their degree of cardiovascular disease. So, do you have no symptoms? Do you have symptoms only with exertion? Do you have symptoms with limited physical activity? Do you have symptoms at rest? So an individual with symptoms at rest would be classified a class 4 versus an individual who only has symptoms with exertional activity. They may be classified a class 2. And then A, B, C, and D is depending on the amount of anatomic disease seen, such as on an echocardiogram or MRI, etc. And then you can classify the individuals in both a functional state and an objective state, such as class functional 2, objective 4, etc. For this class and quiz and exam, I would like you to be able to focus and understand the 4 functional classes, okay? 1, 2, 3, and 4. So if I gave you a scenario of a patient, I told you how severe their symptoms were, I would want you to be able to classify that as functional class 1, 2, 3, or 4, okay? And then ambulatory management of heart failure. What are we trying to do with the drugs to treat an individual in heart failure? So first group of drugs, let's try to get rid of some of sodium and water by using your diuretics. So hydrochlorothiazide, spironolactone, and furosemide, maybe the 3 most commonly used diuretics. You know that when individuals diurese off water, in sodium, they also lose potassium. That could be problematic. So many people on daily diuretics are also on potassium supplements. 2 beta blockers, carvedilol and metoprolol, have been shown to be extremely effective in management of heart failure. And what the beta blockers doing is they're minimizing the chances for ventricular remodeling, and they're decreasing the wall tension in the ventricle. And by decreasing that tension and hypertrophy, you actually get a more effectively pumping heart. Kind of interesting how that works, that a beta blocker actually leads to more efficient contractility of the heart, and that's main reason for that is by reducing the wall tension. We talked about vasodilator drugs like nifedipine and organic nitrates that can help relieve some vasoconstriction. So the heart has less pressure that it needs to pump against if you got the systolic pressure down. Captopril, losartan, aliskiren, mentioned those really quickly. We talked about hypertension. Those are directly inhibiting the renin-angiotensin system. Digoxin, I won't talk a whole lot about digoxin. That's a drug that's still out there. It's kind of falling out of favor. Digoxin is actually making the heart work harder. So you can try to get the heart to work harder by giving digoxin, make it beat harder. But if you have such degree of pathology, it may not work and it actually may be detrimental. So the beta blockers that actually relax the heart and make it pump more effectively rather than harder may be a better option for many individuals. And then the new drugs, sacubitril and Entresto. Let's look at what that is doing in terms of heart failure management. So here's Entresto. It's a combination of 2 drugs, sacubitril, shown on the left, and valsartan, shown on the right. And remember that sartan suffix, that stands for an angiotensin II receptor blocker. So in an individual with heart failure, you have excessive amount of angiotensin II. That angiotensin II is making things worse by causing vasoconstriction and stimulating aldosterone. So we take that out by using valsartan. And the second drug in there, sacubitril, helps us maintain our endogenous BNP. So brain natriuretic peptide is helping us vasodilate and diurese. We want our BNP levels to stay active, and that sacubitril drug is maintaining a longer duration of time of efficacy of our BNP. Technically what it's doing, there's an enzyme called neprilysin. Neprilysin is an enzyme that degrades BNP. Sacubitril inhibits that neprilysin enzyme. So we're able to hold on to BNP for a longer period of time, make it more effective. Do you remember we talked about type 2 diabetes and we talked about incretins and DPP-4 inhibitors? It's kind of like that, where the incretin is the peptide and DPP-4 inhibitors inhibit the breakdown of the peptide. That's what sacubitril is doing, but now the peptide is BNP and the sacubitril is blocking the effect of the neprilysin enzyme. So Entresto has got some very promising stuff being shown in a lot of the heart failure trials. The first one, the Paradigm heart failure trial, really showed the significant improvement in individuals with heart failure when taking this drug. And you can look that up on Google, and you can probably read that Paradigm heart failure trial and synopsis of that on Google, etc. So be familiar with what is Entresto and how that dual drug combination helps an individual in heart failure. All right, myocarditis, this is a little bit different. This is a sudden inflammatory event that happens in the myocardium, leads to very rapid loss of heart failure, manifested by low stroke volumes and low ejection fractions. This is commonly due to respiratory virus infections, influenza, parainfluenza, a lot of different respiratory and non-respiratory viruses can inflame the myocardium and lead to a very rapid loss of cardiac contractility. So normal hearts on the bottom showing you a normal heart, no pulmonary edema, showing you normal myocardium in the histology. Upper picture showing you acute myocarditis, big dilated heart with pulmonary edema, big dilated edematous heart muscles infiltrated with white blood cells, myocarditis, inflammation of the myocardium. And this can be very quickly life-threatening. I know that for those of you that work in cardiology, you have certainly seen young, healthy adults develop influenza or other viral-mediated myocarditis and suddenly go into very rapid congestive heart failure. So think about the viral season, the respiratory viral season. It typically goes from November through March, and you get dozens, if not hundreds or thousands of patients with acute respiratory tract infections from influenza and many other respiratory viruses. Remember, we talked about those respiratory viruses in the pulmonary section. What you want to be able to do as a good clinician is in that big urgent care emergency department waiting room with all these people with the flu and influenza-like illnesses, is we want to be sure that you don't miss that person with myocarditis. So let's think about it. You've seen all these people with a respiratory infection, and then suddenly you're going to have somebody who's going to have a much more severe degree of illness because that respiratory virus now is causing myocarditis. So what do you think you might see in the physical exam of a person with acute congestive heart failure? Think of things that you can look for, things that you can hear, and things that you can feel. And then when you see this, you're going to say, oh, geez, this person is really sick, is an acute heart failure. I better get a stat x-ray, confirm a dilated heart, confirm pulmonary edema. Then I better get a cardiologist and think about, echocardiograms and all the interventions I'm going to need to do, or interventions get started to diurese that patient down and improve contractility. All right, so just think about that. We're not talking a whole lot about the acute management of decompensating heart failure in ICU, but I do want you to understand a little bit about how those drugs work in terms of ambulatory management in treating a person on a daily basis with underlying heart failure. All right, so there's another little exercise that you can think about and test your reasoning skills out on. And then the last form of heart failure here that we want to talk about is sudden cardiac death in athletes. So cardiac arrest outside of the hospital, there's about 300,000 cases of this per year in the USA. And the far majority of them is due to coronary artery disease and MI and VFib. And we'll talk more about sudden cardiac arrest and VFib next unit. Every year in the US, 100 or so high school athletes die of sudden cardiac arrest. Most of those are males. The mean age of those is about 17 years. This can happen in high school or college. Why do young athletes suddenly die? There's a number of different reasons listed here, including drug-induced arrhythmias, right? Remember, we talked about that using these stimulant drugs can lead to vasospasm and MI, and these stimulant drugs can also lead to things like QT prolongation and torsades and VFib. We'll cover that next week. But let's talk really quickly about what is hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy can be something that's relatively silent that leads to sudden death in a young, otherwise healthy adult male, particularly an adult male athlete. So let's take a look at what is hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is exaggerated growth of the myocardial muscle. So remember, too much muscle in the heart is not a good thing. When you get exaggerated growth of cardiac muscle, that can actually lead to impaired ventricular filling, and it also can lead to impaired ventricular contraction. And when the septum itself gets markedly hypertrophied, that septum can actually impinge on the aortic outflow tract and completely block blood flow out of the left ventricle and into the aorta. And you look at that, both of these pictures, you can see the marked exaggeration of muscle in the septum, but look at the upper picture at the black arrow, and you can see how that big, exaggerated, hypertrophic septum is impinging on the aortic outflow tract, all right? This is usually genetic. This is usually due to some type of genetic mutation. Those mutations are usually found in the proteins for cardiac muscle, and that results in exaggerated growth of that cardiac muscle, leading to the hypertrophy. I believe that there's 5 known genetic mutations that account for more than 90% of the individuals who have hypertrophic cardiomyopathy. Individuals are usually asymptomatic. It could be difficult to screen for on a physical exam. They may have hypertension. You may have an S4 gallop. You may see LVH, left ventricular hypertrophy, on a 12-lead EKG. So when you're doing those sports exams on healthy individuals, right, in the people who are having exertional dyspnea, hypertension, S4 gallops, left ventricular hypertrophy on an EKG, you certainly want to refer those people for an echocardiogram to look for hypertrophic cardiomyopathy. Current screening guidelines state that we don't do echocardiograms on every young male who comes in for a sports exam. That just it's just not practical to do an echocardiogram on everyone. Think about that for a while. Think of how many people are using echo now. You think of echo used to be something you just saw in the imaging department, radiology, or just in the cardiology department. Now suddenly echo is everywhere. You're seeing echoes in clinics, you're seeing echoes in emergency departments for sure. You're seeing echoes that are portable. You know, eventually it's already out there. You got echoes that you could use through your iPhone with a transducer. So maybe that's going to change in the future. Maybe as you guys move on in your clinical years here, you may start using more echocardiography more frequently in some of these routine sports exams and doing it on asymptomatic patients versus only on the symptomatic ones. But anyways, it's something to think about. I'm not going to test you on that, but I do want you to understand what is hypertrophic cardiomyopathy and how hypertrophy of that septum can block the left ventricular outflow, and a complete block of that outflow tract is typically what really results in sudden cardiac death in the young, healthy athlete. And very often they're asymptomatic until that fatal event occurs. All right, hypertrophic cardiomyopathy, really briefly reviewed for you there. Pericarditis is inflammation of the pericardial sac. Remember, the pericardium surrounds the heart. If that pericardium becomes inflamed, fluid can now build up in that potential space, and the buildup of fluid in that potential space is what results in cardiac tamponade. Fluid buildup in that potential space can lead to impaired ventricular filling and thus impaired ventricular contraction, and that can lead very rapidly to decreased cardiac output. And cardiac tamponade can be very quickly life-threatening. So what causes pericarditis? A lot of different viral infections, bacterial infections. There can be autoimmune diseases that lead to pericarditis, post-infarction, post-sternotomy and surgery can lead to pericarditis, trauma, radiation, cancer. A lot of different things can lead to pericarditis. Just be aware of that. I take a quick review of pericarditis on those 2 pages, 1163 to 1164, and just at least get a cursory understanding of why inflammation of the pericardium can lead to heart failure. The inflammation of the pericardium can lead to leaking of fluid into the pericardial sac, and that accumulation of fluid inside the sac, forcing itself on top of the heart, can lead to impaired ventricular filling and thus impaired ventricular ejection, contractility. And that's referred to as cardiac tamponade. Usually requires a heroic life-saving procedure where that fluid needs to be abruptly drained. And I know a number of you have seen that done or may have actually done it yourselves. And I think I got a discussion thread this week that if you've had experience with pericarditis and tamponade, you have an opportunity to tell us about that in the discussion thread. Whew, 2 hours and 35 minutes, folks. That was a long one. Again, a lot of stuff in cardiology. You know, we still got one more unit of cardiology to go here to talk about arrhythmias and pediatric cardiology, some other fun stuff. The review at the beginning, I think, was helpful, so I'm happy we did that. We covered a lot, but for those of you, particularly those of you that are in cardiology, you know that we almost, in some of these instances, we just kind of covered it cursory, but at least I think for those of us that don't do cardiology as a career, I think we've got enough there covered to get a fairly good foundation for hypertension, CID, coronary syndrome, and heart failure. All right, I'll shut up at this point. Be sure you complete your discussion threads, read through everybody's, go through the study questions before you take the quiz, and then next week we'll get together and we'll wrap up some more on cardiology. So thank you for bearing with me, and we are out of here.